Hi, everyone. Welcome to our diagnostic radiology case review session today. Our topic is on neuroradiology, focused on the head and neck, and our presenter is Dr. Francis Deng. My name is Zir, and I'm a medical student from Queens in Canada, and I will be moderating this session today along with Nadia. And so the format for our session is a poll everywhere style. So this session will have a case and questions presented in a poll everywhere format. We will share the login information for the session. I believe the link is in the chat. And participants will have a limited amount of time to answer each question.
All right, thank you, Zir, for getting us going. Thank you, everybody, for joining today. I'm just going to give a brief introduction for our speaker. Dr. Deng is an assistant professor at Johns Hopkins University. He is the editor of Radiopedia and co-convener of the upcoming Radiopedia 2024 virtual conference. He was voted Faculty Educator of the Year by radiology residents at Johns Hopkins, and he also co-authored the Head and Neck, Brain, and Spine chapters in the core radiology book. It is our honor today to have Dr. Deng with us, and thank you and welcome. And with that, I will hand it over to Dr. Deng.
All right, does everyone see my screen? So please take a moment to log in to Poll Everywhere at pollev.com/nrad, or if you're on your phone, you can scan this QR code. And our moderators will be monitoring the chat, so feel free to ask questions as we go through each question. You'll have 40 seconds to answer each question. If you get a correct answer, the more quickly you get your correct answer entered, the more points you will score. You can select an anonymous username that will be displayed on the leaderboard after each question. So without further ado, let's get started. We have a patient with neck pain. What is the diagnosis that is seen on these images? Okay, and the correct answer is arterial dissection. Those of you who follow me on X might have seen this image set and question posted 2 hours ago, so you may have had a head start here. The correct answer is arterial dissection, because as we see on this axial T1 non-contrast image, there is a crescentic T1 hyperintensity associated with the right vertebral artery. It's not as well seen on the axial T2 weighted image because fat is bright, as well as this intramural hematoma, but this represents an intramural hematoma within the right vertebral artery associated with arterial dissection. All right, so many people got this right and got the full 1,000 points. Our next case is a patient who has stridor. They were intubated recently. They have stridor post-extubation. What axial level of the airway are we looking at on this image? All right, very good. The majority of you got the answer correct, which is subglottis. So the terms supraglottis, glottis, and subglottis refer to axial levels of the larynx. The landmarks that we can recognize on axial imaging is that the subglottis is at the level of the cricoid cartilage. So look for this U-shaped cartilage. And inside, the normal mucosa should be barely perceptible, but in the case of subglottic edema, there is diffuse thickening of this mucosa lining the subglottis. At a higher level, the vocal cords will come together. That would be the glottis. And then above the level of the glottis would be the supraglottis, which is at the level of the epiglottis and the aryepiglottic folds and the arytenoid cartilages. The trachea would be lower down below the level of the subglottis, and you would be able to see tracheal rings at that level. All right, we have some leaders, 6 people tied at 2,000 points. This patient has periorbital swelling. What is the diagnosis? We have sagittal and coronal CT images in a bone window. Someone said the poll isn't letting me answer. Try refreshing it. We have some people able to register their answer, as we see in the count in the upper right corner.
It should be working now.
Okay, there may be a certain lag. And of the people who were able to register an answer, half of you got the answer correct, which is an orbital blowout fracture. Now, this was a confusing case because the history of trauma was not provided. But what we see in this case is that there's emphysema in the subcutaneous tissues of the upper eyelid on the right, and that there is a discontinuity of this plate of bone that separates the orbit from the frontal sinus overlying. The frontal sinus on the right, aside from this focal abnormality, is not opacified. And so these findings are most consistent with an orbital roof blowout fracture, in which part of the orbital fat has herniated upwards, and then some of the air in the frontal sinus is dissecting into the soft tissues below. So you get this appearance of soft tissue and air mixed together in a defect of the orbital roof. Now, the answer is not postseptal necrotizing cellulitis. I would be showing you more soft tissue swelling in the preseptal or postseptal soft tissues, which are not displayed on these bone window images. And this, any soft tissue thickening is just from post-traumatic kind of swelling that is seen here. The key to recognize is the kind of very smoothly flipped up defect of the orbital roof. Okay, let's try the next question. Hopefully the poll works. This patient is presenting with neck pain. What is the diagnosis? Good. It looks like some people are able to register their votes. There are 86 participants in the Zoom, 34 people answering so far. Okay, very good. A slight majority of you got the answer correct, which is calcific tendinitis. The findings on the imaging are twofold. Number one, there is a thickening of the prevertebral and retropharyngeal soft tissues with this low density that's consistent with a retropharyngeal or prevertebral effusion or edema. It's not very rim enhancing. Notice that there is contrast applied on the CT scan. And in addition to this, when we see the retropharyngeal edema, we want to ask, like, what is causing it? And so we see this amorphous calcification immediately inferior to the C1 anterior arch, right? So this is where the longus colli tendon inserts on the C1 anterior arch. So the tendon is here. This is an entity that is a form of hydroxyapatite deposition disease, more common associated with rotator cuff tendinopathy, rotator cuff calcific tendinitis. but the same pathophysiology can occur in the neck. The patients can present with dysphagia, odynophagia, sometimes have elevated white count or kind of a low subjective fever, low-grade fever kind of symptoms. So it's confused for an infection. But the key to distinguish this from a retropharyngeal abscess is the lack of thick rim enhancement around this retropharyngeal collection, and then the presence of amorphous calcifications inferior to C1 suggests the diagnosis of calcific tendinitis, which is then treated with anti-inflammatory drugs like NSAIDs, naproxen, ibuprofen, and so forth, and not with antibiotics or surgical drainage. All right, guess 469 is pulling ahead. This is a patient who had dysphagia after a recent Chiari decompression surgery. What is the diagnosis? Now look at all corners of the image. Okay. I gave you a hint by asking you to take a look at all corners of the image. So the imaging of this cervical spine was performed because the clinicians wondered whether the patient had developed syringobulbia, which you guys chose, but is not the correct answer. Syringobulbia is when you have syringomyelia that extends all the way up to the medulla oblongata. And so you would see in syringobulbia T2 hyperintensity in the center of the medulla oblongata, expanding it, and that can cause symptoms of lower cranial nerve palsies due to the stretching effect on the lower cranial nerve nuclei that are residing within the medulla oblongata, and that can manifest as dysphagia. This patient actually did not have syringobulbia, but what was apparent on the cervical spine MRI is that, number one, there was prevertebral soft tissue thickening, which is not an expected postoperative finding from Chiari decompression, which is all the way back here. And in addition, on this axial T2 weighted image, you get the sense that there is something mass-like in the left tonsil or peritonsillar tissue, and this represented a peritonsillar abscess. So the cause of dysphagia in the symptoms was unrelated to their Chiari decompression, was kind of an unsuspected diagnosis of tonsillitis with a peritonsillar abscess. And so this is just a corner shot recognition of a T2 hyperintensity in the peritonsillar tissues and associated with some retropharyngeal edema seen on the sagittal image, and not syringobulbia, which would be a T2 hyperintensity in the medulla. Okay, guess 469 is still up ahead. This is a patient who has bilateral conductive hearing loss, and they're referred for temporal bone CT. What is the diagnosis? The upper image is the right ear. The lower image is the left ear. Okay, and the majority of you got this answer correct. It was otosclerosis. The imaging findings in fenestral otosclerosis is this abnormal area of lucency of the otocapsule anterior to the oval window. What I'm showing you are these axial images at the level of the oval window. Here we can see part of the stapes. Here we can see part of the stapes. This was a cone beam CT, a very high resolution scan. And what we see in a normal individual would be this density of the otocapsule bone should be uniform all the way throughout up until the part anterior to the oval window. But in this case, there's an abnormal decreased density anterior to the oval window. And what this represents is otospongiotic bone, this kind of dystrophic bone, starts to overgrow, has a spongy appearance on histology, and it grows over onto the anterior part of the stapes foot plate, fixing it in place and preventing it from vibrating, normally causing a conductive hearing loss. Now, this finding is quite subtle, and so one of the check areas in cases of conductive hearing loss indicated temporal bone CT is always look at the otic capsule anterior to the oval window. Some people refer to this region as the region of the fistula antifenestrum, which is an embryonic structure that is in this region, but not able to be seen on imaging. So this is a case of otosclerosis, and majority of you got this right. Here's another ear case. The patient presented with ear pain and swelling. What complication is shown? This is a 7-year-old presenting with ear pain and fever. And a majority of you got the answer correct, which was epidural abscess. So what is to be recognized on the bone window images is that there is coalescence of the mastoid air cells consistent with coalescent mastoiditis. There's dehiscence of the tegmen mastoidium, and this offers a route of spread of infection from the mastoid cavity into the intracranial compartment. And what we see here on this non-contrast coronal image is that above the mastoid tegmen, there's a fluid collection essentially with a thick rim of soft tissue. This is without contrast, I believe. But what this appears to be showing is that it is displacing the brain upwards. You can see some lower density here that represents a CSF cleft. So we know this is not a brain abscess, and very few people chose the answer of brain abscess. This is more centered in the extraaxial space and in the setting of having a tegmen defect, most likely going to be an epidural abscess. It has a classic biconvex contour to it. Now, this is not the correct level to be evaluating the sigmoid sinus. And if there were sigmoid sinus thrombosis, it would not be this large. Okay, sigmoid sinus would be quite a little bit smaller, but also it would be more posterior to this coronal section. Okay, Mo is pulling up ahead. This patient has a neck mass. What is the most likely diagnosis? This is a CT angiogram of the neck on axial and sagittal sections. Very good. A plurality chose the correct answer of vagal paraganglioma. So first of all, where is this mass located? This is located in the upper neck, about the level of the C1 and C2 vertebrae. It is going up and probably touching the skull base, but it's not really centered in the skull base. It's centered just slightly below the skull base. It's not centered at the carotid bifurcation, which is where you would have a glomus body tumor, a carotid body tumor. So the answer choice of carotid body paraganglioma is not correct because this is too far superior from the carotid bifurcation. And so then we're kind of left with neck masses. This is centered too low to be a jugular paraganglioma. That would be more centered at the jugular foramen as opposed to, an inch below it. Then we're left with the choice of sympathetic chain schwannoma and vagal paraganglioma. So those can both appear in this location. What this location is the poststyloid parapharyngeal space. Let me point out a few dots on this image for you. This like really dense small dot here is the styloid process. And when a mass is arising behind the styloid process and anteriorly displacing it, you know you're in the poststyloid parapharyngeal space. Here are some two other dots. So this is with the internal carotid artery and external carotid artery, and these are being displaced anteriorly. And so this again verifies that you're in the poststyloid parapharyngeal space. Now, what are masses of the poststyloid parapharyngeal space? They can be paragangliomas, they can be nerve sheath tumors, such as schwannomas. And the way that we can distinguish them on these images is that we know this is a CT angiogram, and we see all of these dots of enhancement within the mass on a CT angiogram that suggests that this is a highly vascular, arterially perfused tumor that would be most consistent with a paraganglioma as opposed to a schwannoma. A schwannoma would not be enhancing with these dots of enlarged vessels within the mass in the arterial phase. It would enhance slightly on CT on a delayed phase, and it would be more obviously enhancing on an MRI, which is performed at a later stage of contrast. But on an arterial phase, if you see dots of enhancement within the mass, think of a highly vascularized tumor such as a paraganglioma. And so an older terminology for this would be glomus vagali tumor, but now we just call them paragangliomas. All right, Mo is still up ahead. This is a patient with a right neck mass. What is the most likely diagnosis? We have CT images in a bone window. This was a 20-something-year-old woman, 30-something-year-old woman. Okay. In contradistinction to the prior case, this tumor is centered at the jugular foramen. So even though it's extending down into the neck, what I'm depicting here is that there's a significant intracranial portion coming through the jugular foramen, which is over here. And I'm putting this on bone window to show the bony changes that are associated with this mass. You can see the cortex of this petrous temporal bone around the jugular foramen is thickened. It is hyperostotic. And that brings us to the differential of primary neoplasms of the jugular foramen. There are three main ones. They are paraganglioma, meningioma, and schwannoma. And these can be usually distinguished by the bony features around the lesion. What happens with meningioma, which is the correct answer in this case, is there is hyperostosis. So you can see this thickening of bone around this mass lesion as it squeezes through the jugular foramen. A paraganglioma induces permeative osteolysis of the bone around the jugular foramen. And so that would show bone loss and a moth-eaten appearance to the bone around the tumor. A schwannoma causes smooth remodeling, a scalloped appearance of the bone. It would just look like a very large jugular foramen in that case, and that is not what we see here. In addition, another feature that goes for meningioma is all this mineralization. This calcification of the mass is not really seen in paraganglioma and most schwannomas. And so this calcification, you can imagine if you put this mass anywhere else inside the head, like along the falx, along the tentorium, you see a calcified extraaxial mass, you would think meningioma. And so this was a case of a jugular foramen meningioma that had extended down into the neck and presented with a neck mass. But because of where it is centered and because of what it is doing to the bone and because of the calcifications within, we were highly confident that it was a meningioma, and this was then proven on surgery and surgical pathology. Based on this image, which nerve structure is damaged? Okay, we have a CT image with contrast. you're being asked to infer what nerve injury was present. Okay, a slight majority of you got the answer correct, which was the accessory nerve. Let's see what the CT images show. You see this asymmetry in the musculature over here and over here. So this is the sternocleidomastoid muscle. This is the trapezius muscle. We're at the level of the lower neck, kind of at the level of the larynx. Okay. You see atrophy and fatty infiltration of the trapezius and the sternocleidomastoid muscle. And you have to know that these two muscles are innervated by motor fibers of the spinal accessory nerve, which is cranial nerve 11. Okay. The other choices you guys chose here. So brachial plexus is derived from the lower cervical spinal nerves and innervate the upper extremity, but does not innervate the sternocleidomastoid and trapezius muscle. It would innervate the more distal muscles that are not shown on this image, like the deltoid and the biceps and so forth. The antecervicalis is a network of nerves that are derived from the upper cervical nerve fibers that innervate other neck muscles like the scalenes, but those are not shown to be atrophied in this case. Some people might have noticed that there is asymmetric enlargement of the right piriform sinus. In this case, the patient did have a 10th nerve palsy as well. This is actually the same patient as the prior case with the jugular foramen meningioma. And this patient had cranial nerve 9, 10, and 11 palsies. And what is most prominently being shown is the 11th nerve palsy here, but there was also some imaging evidence of a 10th nerve palsy. All right, so we have some shuffling of the leaders. Caledon is number 1 now. So this patient presented for nasopharyngeal carcinoma staging. What cranial nerve is involved? Again, you're being asked to infer which cranial nerve has been injured or is potentially invaded by the mass. Okay, a plurality, but not majority of you got the answer correct. It is right hypoglossal nerve. In this case, we don't see the primary mass that well, but you get the sense that there's some soft tissue fullness here, this kind of thickening of the soft tissue at the right fossa of Rosa-Miller along the right wall of the nasopharynx here, and this is a right-sided mastoid effusion. And in this case, the mass did creep along up to the skull base. This is not ideally depicted here on the T2 fat suppressed image, but there was involvement of the hypoglossal canal that is not ideally depicted here. The normal hypoglossal canal has some venous plexus here that's very T2 bright, but this was kind of effaced on the right side. But what I was asking you to identify is the appearance of the tongue. And the tongue on the right side, you see the straight line here on the right side, there's T2 hyperintensity. And the tongue is more drooping backwards into the oral pharynx on the right side than the left side. And so this appearance is typical of a right-sided hemi-tongue paralysis due to a right hypoglossal palsy. You have to recognize that the motor innervation of the tongue comes from the hypoglossal nerve and not the glossopharyngeal nerve. The glossopharyngeal nerve is the incorrect answer because that supplies motor fibers to the stylopharyngeus muscle, which helps elevate the palate. but the hypoglossal muscle innervates the intrinsic tongue muscles, and when involved by tumor, will result in a ipsilateral hemitongue atrophy that we see here. So these are denervation changes in the right hemitongue, the ptosis of the tongue into the oropharynx, and the T2 hyperintensity of those tongue muscle fibers. Kaladin up at rank 1. This patient presented with right facial weakness and pain. Which of the following is the most likely diagnosis? Right facial weakness and pain. They obtained a CTA of the head and neck. Okay, a third of you, or 35% of you, got the correct answer, which is carcinoma. So what we see in this case is patient presented with right facial weakness and pain. They got CTA of the head and neck because they wanted to evaluate for an intracranial abnormality, like a central etiology of facial paralysis, but there was no infarct or hemorrhage that would explain that. Sometimes when you have a distal facial nerve lesion that mimics a central lesion, i.e. Mimicking a stroke, because the distal facial nerve lesion might only involve the lower facial nerve fibers, sparing the forehead. When clinicians on exam see forehead sparing facial paralysis, they're worried about a stroke, because the bilateral motor cortices innervate each side of the upper face. And when you have forehead sparing, that points to a central etiology. However, there is an uncommon mimic, which is a lower trunk of facial nerve involving lesion, especially in the parotid gland, which was present in this case. So what we see on the CT image is this abnormal soft tissue density within the right parotid gland. So this is the normal density of parotid parenchyma. It should be somewhere in between water density and muscle density, and that's because it's a mix of soft tissue, but also a lot of saliva that is being held, within in the stroma and the parenchyma of the parotid cells. And in this case, we see this abnormal density that is closer to that of muscle density, as well as some calcifications. Now, a plurality of you chose low flow vascular malformation, and I just want to point out that that is an uncommon diagnosis within the parotid gland. Is possible, but more commonly you would see it in the masticator space, in the masseter muscle or something like that. When you're talking about low flow vascular malformation in the face, you would have a transspatial kind of a cystic appearing lesion. It might have contrast enhancement, it might not, but those would be the kind of things you would think about. In a patient who has facial weakness, and you see this abnormal soft tissue density within the parotid gland, you'd be most concerned for a parotid malignancy. So these malignancies can invade into the vasculature or the nerves, and most often causes a slow onset of a facial paralysis, but on occasion can present with an acute onset facial paralysis, as this patient did in this case. And so it is important to recognize this as possibly representing a malignancy, and it needs further workup with an FNA biopsy, which this proved to represent a carcinoma X pleomorphic adenoma. So what is carcinoma X pleomorphic adenoma? It's when a patient has a pleomorphic adenoma and then that is undiagnosed and untreated, and it transforms into a carcinoma. It can be a carcinoma of any histology. It could be a salivary duct carcinoma. It could be a squamous cell carcinoma. It could be adenoid cystic carcinoma, and so on and so forth. But the overarching term is carcinoma X pleomorphic adenoma, when a mass has some features of pleomorphic adenoma underlying. Now, what we see on imaging are these calcifications. It turns out that the most common calcified mass of the parotid gland is a pleomorphic adenoma. When you see calcifications by themselves in the parotid gland, first you would think about inflammatory etiologies like sialolithiasis, prior inflammation causing kind of granulomatous inflammation, and the sequela are just like punctate calcifications. But if you see calcifications with soft tissue density around it, replacing the normal density of the parotid parenchyma, then you have to think about malignancy. And so carcinoma was the correct answer in this case of this patient presenting with facial paralysis. Okay, Kaladin is still up at number 1. This is another patient with parotid mass. What is the most likely diagnosis? We have MRI, T2 fat suppressed, T1, apparent diffusion coefficient. I'm showing you a region of interest measurement, showing you the average ADC here is 2,300, and the units would be times 10 to the minus 6 millimeters squared per second. And then here is a T1 post-contrast image through the same level. Very good. A majority of you got the correct answer, which is pleomorphic adenoma. Okay, so what are the imaging features here? We have a T2 hyperintense mass. It is low intensity on T1, but avidly contrast enhancing, kind of a heterogeneous manner on the T1 post-contrast images. And then the ADC is measured at a very high value, above 2,000. And these findings are typical of a pleomorphic adenoma. You can have T2 hyperintense non-enhancing masses that have high ADC that would be cystic, but a solidly enhancing mass that has a very high ADC is pretty typical and nearly pathognomonic of a pleomorphic adenoma. Very few masses of the parotid gland have such a high ADC, and this is due to the high amount of extracellular fluid present within pleomorphic adenomas. All of the myxoid stroma allows the free diffusion of water, and this is very high ADC. You could also guess this by the fact that the most common parotid mass is going to be a pleomorphic adenoma. This has a somewhat of a well circumscribed and a benign appearance. You can never be sure with parotid masses, but when you see solid enhancement, very high ADC, you can bet that this is a pleomorphic adenoma. A Warthin's tumor, a more typical appearance would be more intermediate to high signal intensity on T1, and the ADC would actually be low for Warthin's tumor. In a typical setting, the ADC, there would be areas that are like 800, 900 ADC. All right, Kaladin is still up at front. Hearing loss and vertigo. What is the diagnosis? So we're showing you axial temporal bone CT and a T1 non-contrast image. Somebody asked for the prior question, would it be bright on DWI as well? Yes, a pleomorphic adenoma would be bright on the DWI trace image because of the T2 hyperintensity shining through. Oh, okay, a vast majority of you got the answer correct, which is great. This is an endolymphatic sac tumor. So the way to recognize this entity is to first recognize that you're at the axial level of the endolymphatic sac. Okay, and so at this axial level, you should be near the level of the lateral semicircular canal. And looking behind it, this mass is centered retrolabyrinthine. And so this is the region where you would expect to see the endolymphatic duct, which resides within the vestibular aqueduct on CT, and on MR, if we visualize the fluid-filled structure, we would call it the endolymphatic duct. And posterior to the vestibular aqueduct, sitting along the posterior face of the petrous bone within the layers of dura would be the endolymphatic sac. And when you have a tumor of this organ, it's usually like a papillary adenocarcinoma type tumor. It causes a permeative erosion of the posterior petrous temple bone. And characteristically, it also has areas of T1 hyperintensity, intrinsic T1 hyperintensity representing either proteinaceous or hemorrhagic components to this papillary adenocarcinoma type tumor. And so this is a classic appearance of anolymphatic sac tumor. Sometimes this is confused with paraganglioma of the jugular foramen, which would be centered at a lower axial level. So it's important to know what axial level you're looking at, whether you are at the level where the anolymphatic sac is, or you're at a lower level where the jugular foramen is. All right, Kaladin and Destroyer of Worlds at number 1 and number 2. The next patient has diplopia. What is the diagnosis? We have an axial T1 pre-contrast image and an axial skull base CT on a bone window. Okay, a vast majority of you got the answer correct, which is cholesterol granuloma. The key to this case is recognizing that this is a T1 without contrast image. Take a look at the nasal mucosa. This is non-contrast. I already told you it was non-contrast, but sometimes people are confused by the fact that there's bright signal intensity within the vasculature, but this was obtained with the T1 flash technique, which is a gradient echo-based technique that has the flow related enhancement, kind of like that you see on a time of flight MRA that you can see in the vessels here. So it's important to recognize this is a non-enhancing lesion by recognizing the nasal mucosa is not enhancing. This is intrinsically T1 hyperintense and located at the petrous apex, causing this erosion of the bone of the petrous apex. And when you see intrinsically T1 hyperintense lesion of petrous apex eroding bone, then this is classic for a cholesterol granuloma. This T1 hyperintensity is due to blood products like methemoglobin within this lesion. It has nothing to do with cholesterol or granulomas per se. It is only named that because for historical reasons. And this is basically a chocolate cyst, a blood cyst that over time is accumulated, is unable to drain, and so erodes the bone and can cause expansion related symptoms to the regional structures like cranial nerve 6, which runs through a small dural canal called the Dorello canal that is immediately adjacent to the petrous apex, and patients can present with diplopia. Our next patient presented with nasal congestion. What is the most likely diagnosis? I'll say the left-sided images are T2 weighted fat suppressed images. The right-sided are non-contrast sinus CT in soft tissue window. Okay, a great majority of you got allergic fungal rhinosinusitis. What we see on the non-contrast CT images is the presence of complete opacification of bilateral ethmoid air cells in sphenoid sinuses, left maxillary sinus, and left nasal cavity. And it's opacified with this very hyperdense stuff with the rim of more hypodense stuff. And it seems to be expanding beyond the sinuses. It's kind of bulging out the bony margins and thinning it out. There's bony remodeling of the posterior wall of the maxillary sinus and protruding into the infratemporal fossa here. It's not like a hyper, infiltrative. It's not like it's causing much edema in this retroantral fat, and but it is kind of remodeling the bone and kind of bulging out. And it's really hyperdense. So what is that hyperdensity? It's not, don't confuse it with contrast enhancement. Notice that the carotids are not enhancing on these images. And on the MRI, we see a complete lack of signal in here. And this is due to mineralization that's kind of collected by the fungi, and that causes signal dropout. And it's also because this material is so devoid of water. It's very dried out. It's inspissated. It's like a peanut butter consistency to this. These concretions are so devoid of fluid signal that it can appear, it can be mistaken as aeration of the sinuses, but these are just thick kind of concretions of fungal elements and very desiccated mucin. And this represents allergic fungal rhinosinusitis. So there are cases that are severe, and that can cause bone remodeling. But it's important not to confuse this with more aggressive neoplasms or invasive fungal sinusitis. So this is allergic fungal rhinosinusitis. Our next patient has right eye pain and a recent tooth infection, which may or may not be related. Which of the following is the most likely diagnosis? This is a CT post-contrast of the sinuses, axial and coronal images. Correct answer is carcinoma, which a majority of you got. So the key to this case is recognizing that this is a contrast enhanced scan, and this looks quite dense and localized, and this is most consistent with a contrast enhancing mass of the ethmoid sinus that is bulging into the orbit. Notice the lack of fat stranding in the adjacent orbital fat, and the very localized appearance to this, and kind of high attenuation appearance that is suggestive of contrast enhancement on this post-contrast scan. So this was a carcinoma. This was a really high-grade carcinoma called a nut carcinoma, but we wouldn't be able to predict that on CT. A nut carcinoma is a rare kind of a poorly differentiated carcinoma of the sinonasal tract. Can occur in other parts of the body at the midline, like the mediastinum or the gonads. And unfortunately, this patient turned out to have this very high grade sinonasal carcinoma. It was initially mistaken as sinusitis at an outside hospital, but it turned out to be malignancy. So it's important to recognize that. This patient has dizziness after mastoidectomy bowl debridement. So they had a prior canal wall down mastoidectomy for cholesteatoma, and they went to their otolaryngologist and had their mastoid bowl debrided and cleaned. But afterwards, they developed vertigo and presented to medical attention, had a CT scan. What is the diagnosis? Just so you know, we're more than halfway through now, through the entire case set. I have 35 total cases. And the correct answer in this case that the majority of you got was paralymphatic fistula. So the major finding in this case is the presence of air within the vestibule, and that is not a normal finding. that suggests the abnormal communication between the labyrinth and the outside world. And you might call this finding pneumolabyrinth. And the presence of air in the labyrinth suggests that there's an opening, such as in the oval window. And what was hypothesized to have happened in this case is that during cleaning of the mastodectomy bowl, the stapes got dislodged and avulsed off of the oval window, resulting in an opening in which air could get through one way, and the perilymph can leak outwards into the ear. And the loss of fluid and the introduction of air causes acute vertigo. And so this is what is meant by the phrase perilymphatic fistula. There's an abnormal connection between the perilymph and the outside world, the epithelium on the outside. Some people chose emphysematous labyrinthitis, which is not consistent with the history here that this was immediately after a debridement of the bowl. So we want to think about some kind of traumatic iatrogenic etiologies. And I kind of made up the entity of emphysematous labyrinthitis. Okay, Kaladin and Disorder of Worlds still in the leaderboard there. Next patient has right ear pain and hearing loss. What is the diagnosis? This is a coronal non-contrast temporal bone CT. I'll tell you, this patient is 80 years old. They've had severe ear pain. They were treated as an outpatient with Augmentin and Ciprodex drops with initial stability, but worsening pain after a couple of weeks. And so they presented for imaging evaluation. Okay, the correct answer that the vast majority of you got right was necrotizing otitis externa. This is also known as malignant otitis externa. It's called malignant otitis externa not because it's a malignancy, but because it's an aggressive infection. And what we see in this case on imaging is the presence of bone erosion of this inferior part of the bony external auditory canal. The bone here that is comprised of the tympanic temporal bone, or the tympanic plate, should extend all the way out laterally over here, kind of flush with the mastoid cortex up on the top. But we see a lack of bone here, and this is due to the aggressive infection of the external auditory canal, otitis externa, now extending into the bone and the soft tissues underneath the bone, usually in the entity of NOE or MOE, necrotizing otitis externa or malignant otitis externa. Now, most of you got this right, so I'm not going to belabor this any further. Kaladin and Mo up ahead on the leaderboard. Next patient has neck mass and subjective fever. They're 30 years old. What is the most likely diagnosis? Now, at the bottom here, I have a CT scan of the chest coronal section obtained 1 year prior, related to history that was not immediately provided with this referral for a CT neck. And what we see on the contrast enhanced CT neck is at the level of the lower neck. Okay, the answer is scrofula, and most of you got this right, which is I'm very happy about. The finding to appreciate here on the chest CT is the presence of right upper lung nodules and reticulation, as well as a cavitary nodule, and this is suggestive of post-primary tuberculosis. This patient grew up in Pakistan, had immigrated, had a positive PPD test upon starting their employment here, but declined the treatment for latent TB. They developed these pulmonary symptoms here and were lost to follow-up, and a year later presented with a neck mass. And what we see here is this kind of a rim-enhancing fluid collection with a waste at the supraclavicular fossa extending to the subcu tissue. It turns out that this is a somewhat classic appearance for a tuberculous lymphadenitis that has necessitated its way through fascial planes and creating a collar stud appearance. This is a collar stud abscess and these kind of grow slowly over time and have a appearance of a necrotic collection that represents a tuberculous abscess. And so cervical lymphadenitis due to Mycobacterium tuberculosis is known by the phrase scrofula. Can this occur elsewhere? So scrofula is a term for cervical tuberculous lymphadenitis, but tuberculous lymphadenitis can occur elsewhere, such as mediastinum or, in the body, in the abdomen, and so forth. A 37-year-old woman with bilateral pulsatile tinnitus and headache. Which of the following is the most likely diagnosis? Okay, a majority of you got the answer correct, which is idiopathic intracranial hypertension. When provided the history of a reproductive age woman who has pulsatile tinnitus and headache, one of the first diagnoses that we should think about is idiopathic intracranial hypertension. Now, this is accompanied often by the imaging findings as follows. On a MR venogram, we can see stenoses of bilateral transverse sinuses at the lateral portion, at the junction between transverse and sigmoid sinus. We can see a little defect here that is usually due to a large arachnoid granulation. There's also a contribution by the fact that in the setting of increased intracranial pressure, the brain and the CSF kind of pushes everything outward and narrows the lumen of the dural venous sinuses at the lateral aspects. And you have, segmental narrowing of the dural venous sinuses, as well as focal narrowings due to large arachnoid granulations, which are outpouchings of the arachnoid into the dural venous sinuses, and that's what accounts for this little narrowed effect. That's probably the most sensitive imaging sign for idiopathic intracranial hypertension, but there are other signs as well. The most common but least specific one is going to be partially empty sella, which is evidenced here by expanded appearance of the sella and deflated appearance of the pituitary gland. This is often seen in normal individuals who are older, but in a 37-year-old person, a normal pituitary should not be this flat. And so when we see this, the transverse sinus stenoses, partially empty sella, then we think about idiopathic intracranial hypertension. I didn't mean to show that much on these axial CT bone images. They're kind of thick images, so not easy to appreciate a lot, but there is thinning and probable dehiscence of the sigmoid plate here at the sigmoid sinus groove. And this allows the turbulent flow downstream of these stenoses to be reverberated into the mastoid air cells, and that is perceived as pulsatile tinnitus. That's a very common association with these with this entity. So patients develop these stenoses. There's hyperdynamic flow across the stenosis, and over time, this wears away at the bony wall of the sigmoid sinus, and that loss of the bony wall allows the pulsations within your venous structures to be transmitted into the ears, and that is perceived as pulsatile tinnitus. Okay, Kaladin and Mo up ahead. History of oral cancer 5 years ago. The indicated structure is noted to be stable for 1 year. What is it? This is a CT scan, axial and coronal images. I'm putting an arrow on the finding. CT neck with contrast. Okay, a half of you got the right answer, which is thoracic duct. What we see on the axial image is a rounded um, finding in the supraclavicular fossa that has fluid attenuation to it, a little bit lower than muscle density. And let's take a look on the coronal images. It has a more triangular and tubular morphology to it and kind of blends in into this connection right at the crotch of the internal jugular vein and the subclavian vein. And this is exactly where the thoracic duct empties. And so this represents a focal dilation of the distal thoracic duct right before it empties into the venous system. And this is often mistaken for an abnormal lymph node, but tracing it, you know, superiorly and inferiorly, you would see that out of it comes a tubular structure, which represents the rest of the thoracic duct. And so this is not a metastatic Virchow's node, but a thoracic duct. The history here was misleading. You know, if a patient has a recurrence of oral cancer, it is you know, unlikely to occur 5 years later at a very distal area. And this was an incidental finding that was initially mistaken at the outside hospital for abnormal lymph node. But it turns out it is a thoracic duct. This is a patient who has hyperparathyroidism. What variant is likely present? So I'm showing you the arterial phase image on a multi-phase 4D CT obtained for parathyroid localization. What variant am I showing you, and what variant is that associated with? Ignore the pacemaker and the pacemaker lead that's in the artery, or the vein, sorry. Okay, a plurality of you got the right answer, which is a right non-recurrent laryngeal nerve. So what vascular abnormality am I showing you? I'm showing you an aberrant right subclavian artery. So we have a usual left side aortic arch, and we have this vessel that is taking a retroesophageal course. This is an aberrant right subclavian artery. Aberrant right subclavian artery is associated with a non-recurrent ipsilateral laryngeal nerve. So normally the recurrent laryngeal nerve loops down around the subclavian artery, but this looping down does not occur embryologically if the patient has an aberrant subclavian artery. And so it is non-recurrent, meaning it kind of goes down the neck with the branches off the vagal nerve and goes directly to the voice box without taking an inferior loop and coming up. And so this is important to recognize in parathyroid localization scans because this represents a surgical hazard. The fact that the laryngeal nerve is non-recurrent, if the surgeon doesn't know about that, they may accidentally injure that nerve because it's not in its usual place. So right non-recurrent laryngeal nerve. And the opposite side might be true. If you had an abnormal right-sided aortic arch with an aberrant left subclavian artery, then you would have a non-recurrent left laryngeal nerve. Okay. This patient has a lump under their chin, presents for a CT of the neck. What is the diagnosis? I'm showing you this is the lump that is palpated. Let it loop one more time. Take a look at this region. One more time. This region. Okay, wow, a majority of you got this answer correct, which is sublingual gland herniation. So what this represents is a defect in the mylohyoid muscle, which is kind of the floor of mouth muscle sling. You can think of it as the levator ani of the mouth. And this forms the floor of mouth, but often you can have a defect in this muscle called a mylohyoid boutonniere. Mylohyoid boutonniere allows the sublingual gland, which usually sits in the floor of mouth, to then herniate down underneath the mylohyoid into the submandibular space. And when large enough, it can be palpated, present as an abnormal kind of a submandibular space lesion. Now, we can recognize that this is the sublingual gland because it has a kind of intermediate density between water and muscle. And so that's the typical density of salivary gland. And that is this appearance of this. And you can like trace it up toward into this defect into the floor of mouth. So this is a what's known as a sublingual bouton herniating through a mylohyoid boutonniere. Now, the ipsilateral submandibular gland is a little bit fatty atrophy, but that's a separate finding here. Somebody asked, does this count as a plunging ranula, or does that have to be mucus retention cyst? So a plunging ranula is when you have a kind of a retention cyst of the sublingual gland that then falls over the back of the mylohyoid and goes into the submandibular space. So that would have to be the presence of fluid-filled kind of a cystic salivary retention cyst, and usually goes beyond the posterior edge of the mylohyoid. But I guess you could have the concurrent presence of a ranula and a mylohyoid boutonniere deformity, and the ranula could go through via that boutonniere defect. But in this case, there was not a completely cystic, fluid-filled structure that would indicate a ranula in this case. All right, Kaladin, Mo, Destroyer of Worlds, and then head and neck at number 4. Facial soft tissue tumor with perineural tumor spread. What skull base opening is indicated? There's a coronal T1 post-contrast image through the skull base. I have 2 arrows on some thick infiltrated nerves. What skull base opening am I pointing to? Okay, a majority of you got this answer correct, which is foramen ovale. So when I'm showing you a coronal image, the foramen ovale is kind of at the floor of the middle cranial fossa, and the foramen ovale carries V3. And so V3 kind of comes up here and goes down towards the mandible. In this case, the patient had extensive tumor that started off with the lip and traveled along the inferior alveolar nerve and up the mandibular nerve, which is V3, and up into here, and then kind of also did the opposite route through the contralateral mandible as well, and infiltrated the right V3 as well. But the left V3 was the predominant side. And so these openings represent foramen ovale. So foramen rotundum on a coronal image would look out at you in cross section. That would carry V2, and that would be somewhere in this region, but more at an anterior section than seen here. So remember that foramen ovale goes down inferiorly towards the infratemporal fossa, whereas foramen rotundum will exit out into the pterygopalatine foramen. On a coronal image, you'll be looking at foramen rotundum in cross section. All right, we lost HN down here. So now number 4 is me. The next patient has a facial soft tissue tumor, the same patient actually, as the last case. They have perineural tumor spread. Which of the following nerves passes through the area indicated? So this is a slightly more anterior section than the prior question. We're no longer looking at the coronal section that includes foramen ovale. And that's a hint. All right, and the right answer is cranial nerve V1. So what I'm pointing here, pointing to is a section that's right immediately posterior to the superior orbital fissure. And so this contains many of the nerves that go into the orbit, including V1, 3, 4, and 6. Here, this rounded structure, that is foramen rotundum. Remember, I said that on a coronal image, you'll see foramen rotundum as a circle in cross section, and this is foramen rotundum. Vidian canal would be more infromedial, and then the optic nerve, which carries cranial nerve 2, would be superomedial here in the optic canal. And so this is superior, just kind of right behind superior orbital fissure, which carries V1, 3, 4, and 6. All right, Kaladin Mo, Destroyer of Worlds, and me. Our next patient is a 29-year-old man with jaw swelling. Which of the following is the most likely diagnosis? We have soft tissue window and bone window, CT images through the mandible. And that's CT with contrast. We are more than 2/3 of the way done. Correct answer is osteosarcoma, which the slight majority of you answered. What we see in this case is an aggressive bone destructive process centered in the left hemimandible, and is associated with an aggressive periosteal reaction. Look at this kind of a sunburst type appearance. This is periosteal reaction that's perpendicular to the mandibular cortex. And in addition, there's an abnormal soft tissue mass associated with this. And so this is most consistent with an osteosarcoma or other very aggressive primary bone lesion. Now, some of you chose sclerosing osteomyelitis of Gare, which is a term for a chronic osteomyelitis mostly seen in children, in which you would have sclerosis of the mandible, but it would not have a soft tissue component like this associated with that. Odontogenic keratocyst would be a more well circumscribed lucent lesion of the mandible. It would not have an extraosseous soft tissue component like this. It would not create this aggressive periosteal reaction. Which of the following other types of tumor is this patient most likely to develop? So it's a two-step question. What disease does this patient have? And what other type of tumor are they susceptible to? Okay, very good. So meningioma is the correct answer. So what does this patient have? They have bilateral vestibular schwannomas, and this imaging finding is nearly pathognomonic for NF2-related schwannomatosis. This is previously called a neurofibromatosis type 2, but has recently been renamed because people recognize that in NF2, you don't have neurofibromas. And so now it is called the NF2 gene related schwannomatosis, falls under the umbrella of disorders that have a genetic predisposition to developing schwannomas. And the most common is NF2 related schwannomatosis, which is due to alterations in the NF2 gene. Now, you can remember NF2 by the acronym MISME, MISME, which stands for multiple inherited schwannomas, meningiomas, and ependymomas. And so this patient is at risk of developing meningiomas. And so we should look carefully for evidence of meningiomas when evaluating a brain MRI that shows bilateral vestibular schwannomas. This patient has conductive hearing loss. What is the most likely diagnosis? see a coronal CT of the temporal bones and an MR image that you'll have to guess what it is. Okay, what kind of image is this? This is a coronal DWI with a propeller method, which is a non-echoplanar imaging technique to perform diffusion weighted imaging. And it is showing high signal intensity in this abnormality that on CT appears as opacification of the middle ear cavity. And so when you see something very bright in the temporal bone on a non-echoplanar DWI image, you're going to think immediately that this is a cholesteatoma. Uncommonly, you might have some purulent inflammatory fluid in the ear that mimics this, but by and large, this is going to represent a cholesteatoma. So that is the correct answer here. And the best way to visualize these by MRI is some kind of non-usual DWI technique that is either spin echo based, like propeller, that samples case space in a more efficient manner, or a readout segmented kind of echoplanar technique. All these techniques kind of reduce the distortions in the image that are due to eddy currents when you have sudden change in the susceptibility of brain tissue and the bone. So non-echoplanar imaging is kind of a go-to technique to visualize cholesteatomas by MRI. Congenital, yes. Somebody asked that this is congenital. So this is an unusual location for acquired cholesteatomas. And so it's possible that this is a congenital cholesteatoma. So acquired cholesteatomas typically occur a little bit more superiorly in Prusak space. And this is kind of larger and more inferiorly. And apparently the tympanic membrane was intact on physical exam here. So this was thought to be a congenital cholesteatoma, yes. This patient had a recent thyroid cytopathology, like a FNA biopsy that was suspicious for a follicular neoplasm, and additional imaging was obtained. What is the imaging finding? I have some live action ultrasound images, as well as a sagittal CT of the neck and ultrasound image with color Doppler. Okay, the right answer is tumor thrombus. So this was really hard to see on a CT because the tumor enhanced nearly as much as the jugular vein. And then there was also shoulder-related district artifact for this level. But it was actually in this region that we can see best on ultrasound. We see this abnormal echogenic tissue within the lumen of the internal jugular vein that's right here. And then posterior, that would be the carotid artery. And so we can kind of trace this up coming through a vein that dumps into the internal jugular vein that turned out to be like a common facial vein or something. And so this thyroid cancer had invaded into the vasculature, traveled up a vein, and then eventually got its way into the internal jugular vein lumen. So this was tumor thrombus. The way we can tell tumor thrombus from bland thrombus is the presence of flow and contrast enhancement on CT. So flow on color Doppler and contrast enhancement on CT within this filling defect in the internal jugular vein. So in combination with the thyroid cytopathology, this indicates that this is a follicular carcinoma as opposed to a benign follicular lesion. like adenoma. Hyperparathyroidism. What is the most likely explanation for the finding in the anterior mediastinum? Oops. You guys are so good. A vast majority of you got the right answer, which is ectopic parathyroid adenoma. So what are we seeing here? We're on a sagittal image on an arterial phase of a CT neck, part of a 40 CT for parathyroid localization. And what was seen actually here in retrospect, it was missed initially. It was a enhancing lesion in the anterior mediastinum. And this then on sestamib SPECT, correlated with the area of persistent uptake of sestamib in the anterior mediastinum that is most consistent with parathyroid adenoma in an ectopic location. One of the ectopic locations that parathyroids can end up in is the anterior mediastinum. The other places that it can end up in are carotid sheaths, retroesophageal, and those are also search areas to look for if you don't find a parathyroid candidate around the thyroid. Right. So this is anterior mediastinal, ectopic, parathyroid adenoma. This patient has a left cheek mass. What is the most likely diagnosis? CT of the face with contrast on soft tissue and bone windows. All right. Majority you said the wrong answer, which is accessory parotid sialolithiasis. The correct answer was venous malformation, which was the second most common answer here. To distinguish these two, we have to recognize that these calcifications are located within the masseter muscle. Accessory parotid would be anterior and lateral to the masseter muscle, right? The shape of the masseter here is kind of symmetric, and it is not where the accessory parotid is. The accessory parotid would be located along the course of the parotid duct, and that would be located superficial to the masseter muscle. In this case, these calcifications have a rounded morphology and a central lucency that's typical of phleboliths. And so this is a venous malformation. This is the most common location of a venous malformation in the head and neck, like a low flow vascular malformation in the head and neck is within the masticator space and more specifically within the masseter muscle. Someone asked, do we find phlebolith in hemangioma, or is it unique to venous malformation? So the term hemangioma has previously been used in a more loose fashion than it is today. People used to call these hemangiomas, but they have been more recently defined to distinguish congenital and infantile hemangiomas, which are neoplasms, versus vascular malformations, which are mostly what we see in adults, which are malformative lesions as opposed to neoplasms. And so for the large part, we see phleboliths in venous malformations presenting in, as lesions in adults. Can you have calcifications in hemangiomas? Sure. But when I see a master lesion with phlebolus, I'm going to think of venous malformation. Okay, we're getting close to the end here. Fewer than 3 cases left. Okay. This patient has breast cancer and they're undergoing a staging study, including MRI brain to evaluate for metastases. What finding is indicated by the arrows here? All right, dermal filler. Great. It's great that you guys have recognized this, or the vast majority have. I have seen these being mistaken for uh, venous malformations, for lymphatic malformations, or more serious pathologies. But it's important to recognize that when you see T2 hyperintense, non-fat suppressing um, uh, kind of amorphous tissue in the facial subcutaneous tissues, that this represents cosmetic injections of some kind of filler material, usually hyaluronic acid, but occasionally other things as well. And they have this characteristic kind of distribution around the midface, usually around where we have marionette lines along the nasolabial fold, around the mouth, and along the cheeks. And these are common appearance, mostly in middle-aged and older women, but not exclusively, of course. But this is what it was in this case, dermal filler. All right. 55-year-old with left neck mass noticed for 4 months. What is the most likely diagnosis? We have a scrolling contrast enhanced neck CT here. And once you're done answering this question, Nadia has left a link for leaving me feedback. I would really appreciate it if you give me any feedback, give me your ratings. I save all these in anticipation of putting into my educator portfolio eventually. All right, the majority of you got the right answer, which is oropharyngeal squamous cell carcinoma. What we want to see is that this left neck mass, which is indicated by the skin surface marker, is a kind of a necrotic appearing cluster of multiple nodes at left level 2, extending to level 3 a little bit. When we see that in an older individual, the first thing we're going to think about is squamous cell carcinoma that is metastatic to the jugular chain lymph nodes. And among these, causing cystic or necrotic appearance, the most common is going to be HPV-related oropharyngeal squamous cell carcinoma, sometimes HPV unrelated squamous cell carcinoma as well. And so we're going to look in the oral pharynx for the primary lesion. And so as this is scrolling, we can notice there's soft tissue fullness and enhancing lesion in the left tonsil region. It's a little bit difficult to make out because of the dental streak artifacts, but you can see kind of a bulging appearance to the left tonsillar fossa that represented the primary lesion in this case. I'll tell you, in real life, this was initially mistaken by radiologists as parotid masses, but that is not the correct answer. Notice that this is deep to the sternocleidomastoid muscle, which is where the lymph nodes are located, and not superficial and anterior to it, which is where the parotid is. And so this finding represents necrotic lymphadenopathy to the left neck in the setting of a primary lesion in the oropharynx, specifically in the tonsillar fossa that was squamous cell carcinoma. Somebody asked, what stage is this? So the staging of these depends on the HPV status. So it does somewhat depend on having a biopsy of either the neck mass or the primary lesion, whether it is HPV positive or negative. If it is HPV positive, this is relatively early stage because there are only ipsilateral lymph nodes. and the primary mass is, not huge. And so, it's going to be somewhere stage 1 or 2, essentially what I'm saying. But if you want to look up the specific staging criteria, you can go to Radiopedia, search up oropharyngeal carcinoma staging. It has a reproduction of all of the AJCC, UICC staging criteria. And I refer to these pages all the time when I'm reading a staging head and neck, staging a head and neck cancer CT study to make sure I'm covering all the points that are pertinent positives or negatives with respect to staging these tumors. All right, Kaladin, Mo, and Destroyer of Worlds. All right, coming to the end here. Which of the following structures is most likely intact in this fracture pattern? So it's a 2-step question. What fracture pattern is this? And which of the following answers is spared in this fracture pattern? This is the final question. Somebody on the prior question asked, where was the primary? The primary was in the tonsillar fossa, the left tonsil. It was the soft tissue lesion, partially streaked through by dental artifact, but I'll show it one more time after this one. Okay, the answer nearly everyone got right was fossa of lacrimal sac. So what we see here is a zygomatico-maxillary complex fracture. So a fracture, the tetrapod fracture is a fracture of the zygomatic arch, anterior and posterior walls of the maxillary sinuses, zygomatico-frontal suture, and the lateral orbital wall, which is near the zygomaticosphenoid suture, and then the zygomatico-maxillary buttress, which includes the inferior orbital rim and orbital floor here. And so what this involves is the lateral part of the midface, and it would spare the fossa of the lacrimal sac, which is located at the medial part of the orbit. And so unless you have an NOE fracture or a Lefort type 2 fracture, a Lefort 2 fracture, then you would spare the fossa of the lacrimal sac. So the ZMC fracture is in the lateral midface. It does not involve the lacrimal sac. It might involve the region of the lacrimal gland, but it's important to distinguish lacrimal sac from lacrimal gland. And so I'm going to return to the prior question one more time just to show where the primary lesion was right here. Primary lesion located in the oropharynx right here. So if you were able to window this, you can window it harder, you would see slightly contrast enhancing lesion causing that soft tissue fullness in the oropharynx. All right. Thank you so much for participating. Look at that confetti. Kaladin is the winner of this competition, followed by Mo and God at number 3. So thanks so much for participating. And for those of you who came in late, you'll be able to catch the video, post it at a later date onto YouTube, and post it in the Discord channel, I believe.